and welcome to International Diabetes Update 2020 by SAFES. While we extend our warmest greetings to all the expert panelists for today and also the virtual attendees, we sincerely hope that all of you are keeping well and safe. During these challenging times, sharing knowledge, information, and expertise is of utmost importance. And that's the very reason why SAFES was committed to host the Diabetes Update and bring together the global and regional experts in the field onto this virtual platform. Let me briefly tell you about SAFES. Our South Asian Federation of Endocrine Societies was founded back in 2013 when the endocrine societies of Bangladesh, India, Nepal, Pakistan, and Sri Lanka got together here in Colombo. Since then, it has been the hub for regional excellence in diabetes and endocrine care. And now, we are delighted to be joined by Afghanistan and Maldives, the newest additions to the SAFES family. The Dhaka and Colombo declarations, several regional guidelines, and the biennial scientific sessions are among the key highlights of SAFES activities. And for today, there is an exciting lineup of lectures, plenaries, and roundtable discussions, which I'm sure would be very informative and thought-provoking to all of you. Therefore, ladies and gentlemen, without further ado, let us now proceed to the program. And to commence the inauguration ceremony, it's my pleasant privilege and honor to invite Dr. Noel Somasundaram, President SAFES, consultant endocrinologist from Sri Lanka. Over to you, sir.
Ladies and gentlemen, from Sri Lanka, as well as from the South Asian regions and from across the globe, to the more than 1,000 delegates who are watching us from across the globe, particularly from the South Asian region. It is also notable that this is also the third day of the Pakistan Endocrine Society's annual sessions, and we are fitting in as the day 3 of the Pakistan Endocrine Society's meeting. So we bring greetings particularly to PES and best wishes to their annual sessions. And we hope that you had wonderful sessions and inauguration, and that you will continue to enjoy this week as you progress. And we bring you, as has been brought about by Harsha, a wonderful day packed with wonderful program, packed with discussions, plenaries, as well as other discussions delivered by experts in the field. South Asian Federation of Endocrine Societies was formed not long ago by our regional countries coming together to foster the care of endocrine and diabetes and metabolic care for this region. So we have Sri Lanka, India, Pakistan, Bangladesh, Afghanistan, as well as Nepal and Maldives, as well as Seychelles, joining us as either members or as our associate members now. So we have gone a long way forwards, and we have our vice presidents and past presidents and patrons standing by to give us a small talk in this inauguration session. And I thank all of our past presidents and our patrons for guiding us so far. We have achieved a lot, and there are many challenges. Particularly this year had been challenging because all of our programs that had been built on physical meetings had to be cancelled. But we are glad that we are coming in together in this virtual format, and we are looking forward to carrying forward our vision to foster endocrinology and diabetes in this region. So without further taking your time, let me hand you back to progress with the program. But let me welcome you and ask you to stay with us throughout the day, because we have a wonderful set of program arranged for you. Enjoy.
Thank you, sir. And let me now invite Professor Sarita Bajaj, the founder president of SAFES, director professor and head of medicine, MLN Medical College, Allahabad, India. Over to you, madam.
Script the success story of SAFES, just starting with a handful of people who were destined to get together on that fateful day, 17th January 2013 in scenic Colombo. SAFES has come a long way with many more constructive committees, subcommittees, and committed members. So this regional association of 5 countries now includes Afghanistan and Maldives. Soon we may be adding Seychelles as well as Myanmar. The first academic meeting was held at Hyderabad in August 2013, where the atmosphere was marked by joyful camaraderie, celebrating South Asian unity and friendship. Subsequently, it was Dhaka in 2015, Lahore in 2017, Slendo 2019 at Colombo, and the next meeting is scheduled to be held in Kathmandu, Nepal in 2021. Apart from these scheduled events, every member country has made it a point to include a special session on SAFES during most of their conventions, conferences, conclaves, or CMEs, like the one Noel just told you. On the 3rd day of the Pakistan Endocrine Society, we are logging in. Then we had Mood 2020 in Hyderabad, Decon 2020, which also had a session of SAFES that was held virtually. Public education camps have also been held in Nepal. Many creditable publications, position statements, consensus statements, guidelines, and the prestigious declarations, that is Dhaka Declaration and Colombo Declaration. Each president has gone all out to do something innovative, which has been a trendsetter. Be it Dr. Farooq Pathan of Bangladesh or Dr. Abbas Raza of Pakistan. They have been the soul and life of SAFES. Dr. Abbas Raza started the campaign Run for a Healthy Life, and you saw the beautiful pictures when we became live. That was in Lahore, November 2017, aiming towards an active and healthier nation. Counting every step, adding up to 1 billion steps, and also initiating a free insulin scheme for type 1 diabetics. Run for a Healthy Life was launched in Sri Lanka Grand Marathon, January 2018, and later in Nepal. We have Dr. Robin Maskey with us, who was instrumental. Abbas continued a public awareness session even during COVID times. On the 12th of July 2020, reaching to more than 16,000 people to convey the message of healthy living among the general public, promoting the importance of active lifestyle during COVID-19. Dr. Abbas is also working on a joint education project, that is the MedBuzz initiative, and he has been instrumental in drafting the constitution. The current president, Dr. Noel Somasundaram, who is extremely passionate about SAFES, is organizing the current meeting, that is the South Asian Hybrid Summit for Endocrinology, the International Diabetes Update, looking into a SAFES GDM initiative, a very successful SAFES ISC partnership, which has prompted the SAFES ISC ESI bid for perhaps 2024. I would like to end by quoting Noel. The strength of SAFES lies in her members and the close bonds that we have with each other. We come together for a common cause to strive together to find solutions for our region's endocrine challenges. The last decade has been wonderful strides being made, and we look forward to the future with confidence and hope. Thank you very much. Long live SAFES. So as we move on with the program, it is an honor and pleasure for me to introduce the vice presidents, the very, very dynamic vice presidents, Dr. A.H. Amir, who is immediate past president of the American Association of Clinical Endocrinologists. He is the past president of the Pakistan Endocrine Society, chairman Task Force Diabetes Executive Committee, executive member of the National Task Force Diabetes, convener CPSP Endocrinology Pakistan, project director extension DTOC and Insulin for Life project, and member of the FACE Recommendation Committee for the American Association of Clinical Endocrinologists. Dr. Amir.
Ma'am, please, we can carry on with the next Vice President while we wait for Dr. Amir to join.
Okay. Dr. Faria Afsana is with us. Good morning, Faria. She is the Assistant Professor, Department of Endocrinology at Burdham and Treasurer of the Bangladesh Endocrine Society, and she has 47 publications in different national and international journals. Faria, over to you.
Thank you, Professor Sarita Madam, for your kind introduction. Dear audience, dignitaries, President of SAFES, Dr. Noel Somasundaram, and all my fellow colleagues of SAFES, greetings from Bangladesh. I am greatly honored to join the inaugural session of the South Asian Summit of Endocrinology and International Diabetes Update. As we are all running through this global pandemic, and in this situation, I think to be connected virtually to all the surface countries is a privilege. And thank you, Dr. Noel and his team, to organize such an event. And I wish a great success of this conference and International Diabetes Update. And thank you, all the members and all the surface countries, colleagues. Long live surface. Thank you all.
Welcome to Dr. Sanjay Kalra, who is the President of the Endocrine Society of India and Director of Bharti Hospital and Bride, Karnal, India. Sanjay.
Thank you, Madam. Good morning, friends and colleagues from across South Asia, across the world. The Endocrine Society of India has been a very proud and a very privileged founder member of SAFES. We are going great guns. The future in education, endocrine research, endocrine advocacy, and thereby improve endocrine clinical care in our region. If we work together, we can emerge as a strong force in global endocrine education. And SAFES and SAFES member countries' webinars and seminars are sought after by people across the world. Let's continue on this journey together. I'd like to thank our founder president, Madam Sarita Bajaj, my teacher and mentor, Professor Nikhil Tandon, who will be delivering the first SAFES oration in memory of Professor A.C. Amini today. I'd like to thank you for all the guidance you've given me, sir and madam. And I'd like to welcome all colleagues and all juniors to carry this journey forward. Long live SAFES, long live endocrine science, long live endocrine solidarity. Thank you.
Thank you, Sanjay. Could I have my video on, please? You have stopped my video. Anyway, I think I'm audible at least. So we have with us Dr. Prashad Katulanda, who is a senior lecturer in medicine at University of Colombo and honorary consultant endocrinologist at the National Hospital of Sri Lanka. Dr. Prashad has an MBBS from the University of Colombo, MD from the Postgraduate Institute in Medicine, and DPhil, Diabetic Medicine, from the University of Oxford, UK. He has an excellent research portfolio, and currently he is the principal investigator of Sri Lanka for the NCD survey, progress study, and iHealth T2D, which is a European Commission funded project. Over to you, Dr. Prashad. Dr. Amir?
Ma'am, Prasad is
I
not
can
here.
see Dr. Amir. Can you
Yeah.
unmute yourself, please?
Ma'am, Prasad is not here. We can move on to Amir.
Good morning. I will just introduce you briefly once more and for your address as Vice President. You are immediate past President of the American Association of Clinical Endocrinologists, past President of the Pakistan Endocrine Society, Chairman of the Task Force Diabetes Executive Committee, and the Executive Member of the National Task Force for Diabetes. Dr. A.H. Amir, Vice President, Pakistan.
Good morning, everyone. Thank you for arranging this wonderful session. Just a first check. Can everybody hear me? Can you hear me okay?
Yes, we can.
Great. Thank you very much again. I would start by saying that we all know in management of crisis, what we call ABC. We all know that, but I think here ABC very rightly stands for SAFES. In how the organization responds in adversity, I would say. This organization, how would it take things further in adversity? We all know about the COVID. And for me, I would say, what was the behavior adapted? How they reacted to this adversity, and then the basic thing is communication. I think SAFES has done excellent in communicating everybody in this crisis and arranging this wonderful seminar. I wish everybody good luck and to continue with the motive that we will look after the interest of South Asian Federation locally and continue internationally. Thank you very much.
Thank you, Dr. Amir. Do we have Dr. Prashad Katulanda with us? Okay. Then we have Dr. Ali Latif, who is a consultant physician and head of the Department of Medicine at Indira Gandhi Memorial Hospital, Maldives. He is also the president of the Maldives Society of Internal Medicine and is a member of the National Health Research Council. He has played a key role in establishing the newly formed National Diabetes Center and is now working on a project to connect all the islands to this center so that standard care is provided to all the diabetic patients across the country. Dr. Ali Latif, Vice President, Maldives. I don't think he has been able to join us. Dr. Robin Maskey, Vice President of SAFES, Nepal, is the endocrinologist and additional professor, BPKIHS, Dharan, MBBS, MD, FACP USA, FRCP UK, and fellowship in endocrinology and metabolism. He is also Vice President of Dean, Chief Editor, Journal of Diabetes and Endocrine Association of Nepal, reviewer and editorial team member of several prestigious journals, and he has 60 publications to his credit. Dr. Robin Maskey.
Namaste, everyone. Thank you, madam, for such a nice introduction. Since we have a pandemic of diabetes in Nepal and everywhere in the world, So in this pandemic, we are connecting through a virtual. So I would like to thank Dr. Newell and his team and all my friends and colleagues from the Southeast Asia Federation Diabetes Society. So what I want to say is I want to wish best of luck for this International Diabetes update, which we are having every year. I miss all the beautiful sceneries and food of Sri Lanka. Wish I was there for the in the face-to-face meeting with these so good people of all of our friends from all of our Southeast Asian Federation Society. So I would like to wish all the best for this International Diabetes update, and thank you very much. Long live SAFES.
Thank you, Robin. We have with us from Afghanistan, the Vice President of SAFES, Dr. Mohammad Wali Nasiri, is MD, PGD, DFID, CMC India, Associate Professor of Internal Medicine, Division of Endocrinology, Metabolism and Diabetes, Kabul University of Medical Sciences, Consultant Endocrinologist, Ali Abad Teaching Hospital, Consultant Endocrinologist, Noble OPD Clinic, and President of the Endocrine Society, Dr. Mohammad Wali Nasiri.
Thank you very much for your nice introduction. Honorable President and Vice President of the SAFES, Honorable Founder of the SAFES, Professor Dr. Sarita Bajaj, distinguished guests, ladies and gentlemen, I'd like to welcome all of you to this wonderful conference. It is an honor to virtually join you today for this wonderful conference. Dear friends, non-communicable diseases, especially diabetes mellitus, affect us all. We all have parents, relatives, or friends who live with diabetes. Tragically, diabetes caused 4.2 million deaths in 2019 in people aged between 30 and 70. Most of these premature deaths do not occur in rich nations, but among the poorest people in the poorest countries. Each death deprives a family from his loved ones, but it also deprives a nation of a worker. In the name of free trade, we allow multinational corporations to market junk foods to children. In the name of entertainment, we allow our children to spend more and more time in front of television and smartphone screens rather than playing outside. If we are to win the war against premature deaths caused by diabetes, we must also win the battles in our kitchens, shops, supermarkets, restaurants, and school. At this important conference, I urge us all to reflect very deeply on such realities and to promote and to commit to solutions to promote health, protect people, and prevent avoidable death and suffering. Thank you very much.
Thank you, Dr. Nasiri. So we have heard from the vice presidents of SAFES from Pakistan. We had Dr. A.H. Amir. From Bangladesh, we had Dr. Faria Afsthana. From India, Dr. Sanjay Kalra. From Maldives, Dr. Ali Latif. From Nepal, Dr. Robin Maskey. And from Afghanistan, Dr. Mohammad Wali Nasiri. So amongst the committees, we have the founder patrons. Apart from myself, there's Dr. Jyoti Bhattarai, Dr. Shubhankar Chaudhary from India, Jyoti is from Nepal, Dr. Najmul Islam from Pakistan, Dr. A.K. Azad Khan from Bangladesh, Dr. Hajira Mahtab from Bangladesh, Dr. Muhammad Farooq Pathan from Bangladesh, and Dr. Henry Rajaratnam from Sri Lanka. The immediate past president is Dr. S. Abbas Raza from Pakistan. and the SAFES representative in the International Society of Endocrinology is also the immediate past president, Dr. Abbas Raza from Pakistan. And the president-elect is Dr. Deena Shrestha, Nepal. The National Society presidents are Dr. Charles Anthony Pillai from Sri Lanka, Dr. Sanjay Kalra from India, Dr. Khurshid A. Khan, Pakistan, Dr. Muhammad Farooq Pathan, Bangladesh, Dr. Deena Shrestha, Nepal, and Dr. Abdul Wase Sultani from Afghanistan. And the most important post, which is held by Dr. Manilka Sumanatilleke from Sri Lanka, that is of the Secretary of SAFES. It is said that the most precious gift that you can give to any woman is regard and respect. In what we call in Hindi, which I thought sounded much nicer, is Samman. So I cannot thank you all for the regard and the respect which I have received from all my colleagues, my friends, and the whole family of SAFES. Thank you. Thank you very much. Over to the organizers.
Ladies and gentlemen, we are at a historic moment in SAFES. Professor A.C. Amini was a well-loved teacher and a doyen of endocrinology, serving in AIIMS, India. She trained more than 75 endocrinologists, most of whom are teachers and trainers now. She was also one of our founder patrons. Her name is not in the list now because she's no more. She left us a couple of years ago. So one of the things that we wanted to do in honor of her was to do a first inaugural oration. We have never done an oration for SAFES so far. Was that because Professor Amini is no more, was to do an oration in memory of her. And today's oration will be done in memory of Professor A.C. Amini. And we have the SAFES committee has decided to award that to Professor Nikhil Tandon, whose CV you can see shortly in the screens in front of you. Professor Nikhil Tandon is, and the first SAFES oration is awarded to Professor Nikhil Tandon, and I'm glad to award it to him. As you can see, he is well regarded and a well respected and a highly qualified endocrinologist from India, and I invite Professor Nikhil Tandon to deliver the first ever oration of SAFES and in memory of Professor A.C. Amini. Over to you, Professor Nikhil Tandon.
Thank you, Dr. Noel Somasundram. I'm going to try and start sharing my screen. Please let me know if the screen is visible. Just want a confirmation if I can be heard and if my screen is visible. Okay, I would assume, well, good morning, everybody. I need to first thank SAFES for having honored my teacher. Madam taught me when I was an undergraduate, and that you can imagine was several years ago, and it's a very touching and nostalgic moment for me that Madam is being, her name is being recognized and commemorated in the form of this oration. The next thank you, of course, is the fact that I was considered even suitable for delivering this oration, and it's a matter of great honor for me and privilege, not merely because I'm delivering an oration to the SAFES community, but because it's in the name of my teacher. I will be speaking on, and I'm glad when Dr. Sarita Bajaj referred to the fact that Dr. Noel Somasundram is leading a SAFES initiative on GDM. And I will be essentially speaking on the subject of GDM, not so much as GDM during pregnancy, but GDM in the post-pregnancy, the post-delivery years. And I think trying to convey to you the importance of the continuum of care, which we often tend to get missed out. But before I start that, I just wanted to apprise the audience of Professor Ramani, who, as mentioned, was one of the founding faculty of the Department of Endocrinology at AIIMS. It was the endocrinologists were part of internal medicine and then carved a separate department for themselves in 1982. And Dr. Ramani was actually the youngest faculty member in that, of course, evolved into becoming professor and then chaired the department for more than a decade. I, of course, gained a lot from her presence and her guidance all through my years as a younger person in the field. Her major areas of research, actually, and she's contributed significantly to disorders of sexual differentiation, to Cushing syndrome and type 2 diabetes. But I think for us, there were two outstanding features. One was her passion for clinical care, and the other was her compassion for patients. And I think if every one of us can even get a fraction of what Madam had, I think that would make us much better and rounded physicians and endocrinologists. And again, to sort of emphasize the contribution of the Department of Endocrinology at AIIMS and under the leadership of several former heads, especially Madam, was the fact that it's not merely a question of how many people we've trained, but if you look at this map of India and you look at the red stars, you will see that we have managed to populate virtually every single state of the country with former trainees. And that really fulfills the mission for which All India Institute was created, a mission which said that we need to create postgraduate students who would then go ahead to establish their own departments of postgraduate studies in different parts of the country. And as you can see, we've largely been successful, bar a couple of states. We've managed actually to populate each and every state of the country with our former trainees. With this brief introduction, let me proceed to the meat of today's oration, which is with reference to, as I said, the issues of gestational diabetes in the postpartum period and the need for a continuum of care. Now, as you all know, hyperglycemia in pregnancy, and this is information from the IDF, that about 1 in 6 of every pregnancy actually is faced with a problem of hyperglycemia. And out of these, about 85% qualify for the diagnosis of gestational diabetes. Unfortunately, our region, that is the Southeast Asia region as far as the IDF is concerned, but largely including all the countries in our region, is got the highest prevalence of hyperglycemia in pregnancy, as possibly can be seen from this graph. More than about 25% of pregnancies, depending on the surveys that you see. Now, that's nearly not enough. The implication there is not only the implications for the mother and baby during pregnancy, but the other issue, which is of critical importance, is that the future of these women in terms of their metabolic health is also impacted adversely. The overall relative risk for type 2 diabetes in women with gestational diabetes is about 10 times higher than their healthy peers. Now, 10 times is a massive, massive difference in this. And therefore, we need to look after GDM not only during pregnancy to have a healthy pregnancy and a healthy baby at the end of pregnancy, but we also need to provide continuity in care so that this conversion to type 2 diabetes does not happen. Now, are we even peculiarly unprivileged for this also? If you look, and this is a study, while it's from Canada, it compares 3 ethnicities, South Asians, Chinese, and whites, and you'll see that not only was GDM prevalence higher there, but the cumulative incidence of diagnosed diabetes on follow-up in these women was also the highest among South Asians compared to other ethnicities. We've done a little bit of work in this regard, which we published over the last 3 or 4 years. And the first study was when we took a cohort of women who had been diagnosed with GDM using the original Carpenter and Couston criteria. Just over 350 women were screened, and we looked at them within 5 years of their index pregnancy. So the median time happened about 20 months following delivery. The first thing I'd like to really point out here is that calling back women for postpartum screening has been one big speed bump in this journey, not only for us in India, but everywhere in the world. And this is a speed bump which we have to overcome. But what was even more worrying was the fact that at a median of 20 months after delivery, only 1 out of 4 women had normal glycemia. 40% had pre-diabetes, and just under 1/3 of them already had diabetes. Now, if you think of it, these are young people. And therefore, if you compare them, that 1 out of 2 of these women would be developing diabetes within about 2 to 4 years of their index pregnancy if they were diagnosed on the basis of Carpenter-Couston criteria. And if you compare them to a general population, and these are data from the ICMR INDAB study, if you look at women, when you compare them with their peers who are 20 to 20, risk. Now, over a period of time, the criteria used for diabetes in pregnancy has also changed. And a lot of centers now look after the IADPSG criteria. The important issue here is that anybody who has a fasting more than 126 and a post load more than 200 is removed from the diagnosis of GDM and are called overt diabetes. And therefore, by definition, when you're looking at women diagnosed on the basis of IADPSG criteria, we're looking at a slightly milder metabolic derangement than the entire universe, which was diagnosed on the basis of Carpenter and Houston. So we then went back and did the same sort of evaluation limited to AIMS in women who have been diagnosed with GDM on the basis of IADPSG and looked at their postpartum glucose tolerance. And once again, we found that, and this was just over 250 women, that they were normoglycemic about 40%, 60% were either diabetes or pre-diabetes. The diabetes proportion was less, clearly signifying that we'd identified perhaps women with milder derangement. And if we'd again gone back to Carpenter and Houston, these numbers would have been different. But even then, 60% likelihood of dysglycemia is very, very high. And what are the factors which predicted that? Insulin use during the index pregnancy, diabetes in a first degree relative, the longer the duration from the time of their index delivery, the older the individual, the heavier the individual, and if they had any features, clinical or biochemical, of insulin resistance. And at the same time, we'd actually done a very, very small study to evaluate the feasibility of a lifestyle intervention program for women with gestational diabetes in India. Now, we know that the diabetes prevention program had included some women with a past history of gestational diabetes, about 250 women out of the entire cohort of just under 2,000 women. But the US is US and South Asia is South Asia. And we wanted to see whether a group-based intervention would suffice. And we therefore looked at 7 sessions spread over 9 months and reevaluated women first at baseline and then reevaluated them at 12 months. And the 2 things we established was A, that it was logistically feasible, B, that if women came for the second session, they were likely to stay on. Those who dropped out were much more likely to drop out at the end of the first session. And 3, that though this study had neither the objective nor was it powered to actually look at outcomes, we got very encouraging trends that those who participated in this intervention program in a pre and post analysis did lose weight, did improve in their fasting plasma glucose, and did improve in their 2-hour glucose, amongst other parameters which you can see on this table. But these were encouraging data, which has now prompted us to do a much larger study, which is called LIVING, that is Lifestyle Intervention in Gestational Diabetes. And this study is not limited to India, and therefore it is my privilege to present it in front of a SAFES audience. It is a study which includes 19 institutions in Bangladesh, India, and Sri Lanka. So the more details of the protocol for the LIVING study are provided in this paper, which came out a couple of years ago in Diabetic Medicine, and essentially takes you as to how we conducted this study, which actually now is nearing the end. Now, the process of the study was, this is an open label, parallel group. It's a pragmatic, individual randomized control trial, but it's got a blinded primary endpoint adjudication. And I'll come to that in minutes. Obviously, it's open label because women were either exposed to sessions of counseling or no sessions. Very low intensity lifestyle modification program, because one of the things we learned from our early study, which is called Preg Diab Care, which was a feasibility study, was that this is a very challenging part of the woman's life. There is a small baby to be looked after, their household work to be done, and in a proportion of women, they're also working outside the house. As a result, we've actually curtailed the number of sessions, and I'll come to those details in a moment. We decided that we had 1,400 women with prior GDM, and we thought of doing it in 24 hospitals in Bangladesh, India, and Sri Lanka. The primary outcome here was proportion of women with a change of glycemic category at or prior to the final visit. So we would be following up these women and looking for a conversion if they were normal glucose tolerance at the time of their postpartum GTT conversion from normal glucose tolerance to either pre-diabetes or diabetes. And if they were pre-diabetic at the time of their registration, then a conversion to diabetes. And there's a range of secondary outcomes in the form of change in body weight, waist circumference, blood pressure, fasting glucose, physical activity level, and diet. The inclusion criteria are very straightforward. If you were called back for a GTT anytime between 3 and 18 months postpartum and you were not diabetic, that means you either have normal glucose tolerance or pre-diabetes, you could be enrolled in the study. And I'll come to the challenges of that in a minute, and you'll see that anybody who had a confirmed diagnosis of diabetes in this postpartum GTT, anybody who was living far from the hospital because we needed in-person sessions, though I must confess that COVID has demolished that requirement and we've now shifted even to sessions which are on telephone, WhatsApp, Zoom, whatever. Lack of access to a mobile phone because people would be getting SMSs and phone calls. Use of steroids, because if this was steroid-induced diabetes, then it was not relevant, except if they got steroids just for lung maturation, and the likelihood of them moving residence in the next 3 years. This is a study which started in 2016, January, scheduled to be completed in a couple of months from now, but given the COVID interruption, will possibly extend it for another 2 or 3 months. So this is a study schema. Women were first contacted in their pregnancies, in most instances, when they were diagnosed to have gestational diabetes in the standard second and early third trimester GTTs. If they had GDM as per IAD-PSG criteria, which again was a bit of a challenge because a lot of centers actually use DIPSI criteria, but we've decided that this study will restrict women who are diagnosed on the basis of IAD-PSG. They were then consented to contact after delivery. So we said, you've been diagnosed with GDM. We're going to give you some material so that you understand the implications of GDM for your pregnancy, for yourself, and for your baby, but allow us to contact you anytime after 3 months. And why was it 3 to 18 months? Because we said that in any case, we would not like to do an intervention till exclusive breastfeeding is advocated, which is about 6 months in most countries, because doing an intervention during exclusive breastfeeding would be a bit of a challenge. Women and their family members are unlikely to feel the need for an intervention then. If this postpartum GTT led to a diagnosis of type 2 diabetes, they were then recommended for normal care by their physicians. If, however, they had normal glucose tolerance or pre-diabetes, they were individually randomized to either usual care or a lifestyle program delivered over 12 months. They were supposed to be followed up over 24 months, but we had problems in recruitment, so we're down to about a 19 or 20-month follow-up as for now. They were contacted every 6 months, 6 monthly A1Cs, and annual GTTs on follow-up. But as I mentioned, the primary outcome depended on change of glycemic category, and this required a GTT because the diagnosis of IFG, IGT, and diabetes was based on GTT and not based on HbA1c. This is to show you a scatter of the sites. So North, West, and South India, Sri Lanka, and Bangladesh. Bangladesh, everybody was from Dhaka, and Sri Lanka, everybody was from Colombo, though the Indian sites were scattered. And these are our 19 champions who have been, I must say, phenomenal investigators to work with, who've done a great job and allowed us to reach where we are. Okay. But before we decided on the intervention, we already had some information from our feasibility study, but then we went on to conduct a 9-month formative research. And this was very, very critical for us to really come up with an implementation strategy. We did in-depth interviews with endocrinologists, diabetologists, obstetricians, hospital administrators, nurses and auxiliary nurse midwives, and dietitians across all 3 countries in private centers and in public centers. And we did in-depth interviews with postpartum women who had been diagnosed with gestational diabetes in the last 24 months to understand their challenges, and focus group discussions with recently experienced but now postpartum gestational diabetes. So we had a lot of formative research which helped us to come under with this implementation strategy. And what did we learn? And what did we incorporate? The first thing we learned was that we were not on the wrong path, that everybody felt that A lot of effort is required. This is an area where people have not spent too much time and effort, and therefore it must be done. The second thing, which was not surprising but unfortunate, was the fact that there was a lack of cohesion and care between the obstetricians during pregnancy and other healthcare providers after delivery, and therefore everybody came up with the need for multidisciplinary team approach, not only during pregnancy but to ensure a seamless transition of care after childbirth. That any such intervention in the postpartum period has to be patient friendly. If it's hospital visits, you have got to do it maybe on a weekend, maybe on a Sunday morning when the mother can either come with a baby and some other family member, and there has to be short waiting periods. The intervention format, interestingly, we asked them various options. They wanted in-person sessions, they wanted group sessions, and as I said, they wanted short sessions on the weekends. And they wanted group sessions because they said they'll learn from their peers, they'll be able to share their experience with other people, learn from other people, and therefore they were very, very keen for group sessions, and they wanted social support. They said for them to implement anything at home, their families needed to understand their problems, and their families needed to be supportive. Without that, nothing could be done. On the basis of this formative research, we designed the intervention program. As I said, we decided a soft and light touch. So in the first 6 months, there were 4 group sessions, baseline 3 months and 6 months. At the end of the third session, they started getting 2 SMSs every week, which could be audio or video, audio or text. And they got a monthly phone call just to reinforce that. And at the end of 6 months, they also had a 4th group session. Around this time, they underwent the first evaluation using an HbA1c and a measure of anthropometry. And for women who did not meet a predefined target of weight loss in these 6 months, they were then exposed to 2 additional in-person sessions. These were not group sessions, these were individual sessions, and they focused on specific barriers and challenges which the woman complained about during her first 6 months. The whole issue of the SMSs continued all throughout. So every woman got at least 4 sessions. Some women, about half of them, actually got 2 additional intensification sessions, and every woman got 84 SMSs and 12 monthly, overall 12 calls every month, or 1 call every month for 12 months. And this was a 1-year intervention, and after that, the follow-up has been without continued intervention. So I'm going to be able to share with you only the baseline data from this particular study, and here we are. And this is first to highlight, and this is a critical issue which we must remember and we must highlight, because you can only intervene if you have a postpartum GTT. It's a standard of care that everybody who comes with GDM in pregnancy must be called back after delivery to establish what their glycemic status is after delivery. But of the 3,491 women who were registered with GDM during pregnancy, only just over half attended the postpartum GTT. Now, compared to our feasibility study and our early work, which is about 37%, this is a definite improvement. But compared to a target of 100%, this is not. So about half the women did not even turn up for their post-delivery GTT, which is a matter of great concern and which is an important pair where the obstetricians and the health system and the healthcare providers have to find new, innovative, and more efficient strategies to ensure that the woman comes. And I'll tell you the reason why. Nearly 9% of the women who attended the GTT already had diabetes. Remember, there'll be some women who were not even included in the study because the criteria used were IADPSG, so there would already have been some overt diabetes in pregnancy. Of those who were diagnosed with gestational diabetes, 9% already had diabetes within the first year. And that's a lot of women who are in their 20s and early 30s. Of the 1,640 women, which is 90% of those who underwent the GTT who were therefore eligible for participation, I'm actually very proud and pleased to report that 98% got randomized. Now, that's a phenomenal conversion rate because people will even then have the right to refuse. Only 29 of the 1,641 women actually did not agree for randomization. And this is credit to the participating sites and the team of investigators led by the lovely PIs whom I listed in one of my earlier slides. And all except 2 women who were randomized, we had baseline data. 2 of them, even after randomization, because of issues which are technical, we couldn't get the data. So we wanted 1,414 women. We've got just about 200 more than what we wanted. And that's really a big achievement. It's the largest single study for preventing diabetes in women with gestational diabetes done anywhere in the world. And I'm proud that South Asia has shown this. Now, we wanted to do a sensitivity analysis and also look at a reason for why those who did not come were different, or how those who did not come for the postpartum GTT were different from those who came. The first thing was there was a marginal difference in those who were attending private healthcare. A few more of them actually attended compared to those who attended public healthcare. But look at the 2 other important reasons. 23% were not contactable despite having agreed and given multiple phone numbers and an address, and about another 28% refused to participate. So 50% of those who had said yes during pregnancy bailed out at this point in time. There were another quarter, 22%, who had different reasons, and then 2% diagnosed with diabetes. Add that to the 8.8, and we're already crossing 10%. 15% had shifted to a new place, though they had said they're unlikely to shift. So these are health system challenges. But there are also challenges. We need to understand why women who had said yes went on to say no. We lost half the women. And imagine if the same proportion of these women also had diabetes, we would lose a very, very large number. Now, this is the breakup of the women who underwent a postpartum GTT in terms of what their glycemic categories were. Overall, just over 55% had normal glucose tolerance. About 40% were pre-diabetes. About 9% had diabetes. Right? This was slightly different between countries. Bangladesh and Sri Lanka had very similar numbers of people with normal glucose tolerance and very similar numbers of people with IFG and IGT, though the different categories of pre-diabetes were marginally different, and about 10 to 12% with diabetes. India, for some reason, had much higher normal glucose tolerance, nearly 64%, a little lower diabetes, about 7%, and the remainder, which is about just under 30%, who had pre-diabetes. So there was some variability. Remember that the spread of centers in India was all over the country. There was heterogeneity. There was both public and private. There was more clustering of centers within metropolitan Sri Lanka and metropolitan Bangladesh, which may have contributed to this difference. What about the more detailed characteristics? So these were about an age of about 30 years, right? So these are still young women. As already mentioned, normal glucose tolerance at about 63%, a combination of IFG, IGT, and both was seen in about 37 or 38%. And there were differences between the sites, which I have already elaborated in my previous slide. Marginally lower fasting glucose and post-glucose in India. Similarly, marginally lower HbA1c, but that's consistent with the overall distribution of glycemia in the recruited women. Now these are interesting data. 1 out of every 7 women had actually had insulin during pregnancy. A similar sort of number in India and Bangladesh, a little lower in Sri Lanka. The average number of years of education was marginally more in India, about 13.5 years of education, a little lower in Bangladesh and Sri Lanka. But that also has an implication for the number of women who were externally employed. Now, I've already mentioned that this is critical because women who are externally employed will therefore have problems in not only managing themselves at home, the baby at home, the homework, and also external work. The other issue was that there was a very strong family history of diabetes. About 45 to 50% had a family history of diabetes, making it a very important predictor for this category of women. The other issue I'd like to emphasize here was the fact that the mean BMI was about 27. You know, that's a cutoff for obesity for South Asia. 22 to 27 is overweight. At 27 and above is obese. So a very large proportion of women were overweight and obese. But what is equally important is the fact that being normal BMI did not prevent them from getting TDM. About 1 in 3 has a normal BMI, and the remaining 65% or so had either overweight and obese. With that, I'm going to actually sum up what I've told you and come to an end of this presentation, that the thing we obviously focus on is trying to get a GTT done during pregnancy, trying to diagnose women during pregnancy to treat them. But what we've managed not to do so well is following up these women after their deliveries. This is an obvious, accessible, and critical target population to identify and intervene to prevent a rapid transition to diabetes. And you're seeing that in these 28 to 32-year-olds, diabetes is happening much earlier and much more than in their age-matched peers. These women fall between the stools of cessation of obstetric care and failure of initiation of care by physicians. We need an early intervention, but this is a very challenging phase of their life, and they've got a lot on their plate, so we've got to come up with something which is worth their while. The mother's capability, their motivation, and the opportunity they are provided by the health system will impact their behavior, and we need to address all of this. And it's very important to understand that, at least from our early work, our pilot study, and our intervention, the need for a group session, holistic, and the requirement for a participatory care would be of great importance. I'll stop here, and thank you so much for having given me the opportunity to present before this audience.
Professor Nikhil Tandon, the A.C. Ammani Memorial Orator 2020. Sir, on behalf of the SAFES and all virtual attendees, let me thank you for the most insightful oration and also express our heartfelt congratulations and gratitude for the exceptional contributions you have made in the areas of diabetes and gestational diabetes research in regional as well as global perspective. Ladies and gentlemen, that brings us to the conclusion of the inauguration ceremony. And before we move to the academic program, let me now most cordially invite Dr. Manilka Sumantilaka, Secretary SAFES, to deliver the vote of thanks. Over to you, sir.
Thank you, Harsha. Good morning. It's indeed a pleasure and a privilege for me to propose the vote of thanks at this International Diabetes Update 2020, organized by the South Asian Federation of Endocrine Societies. On behalf of SAFES, again, I would like to convey our heartfelt gratitude and many thanks to Professor Nikhil Tandon, the orator of the first SAFES oration in memory of Professor A.C. Ammani. And of course, I would like to thank all the speakers around the globe joining us today, both physically and in virtual means, starting with Professor Anne Donahorst from United Kingdom, Professor Nick Oliver from the United Kingdom, Dr. Pamela Dyson from, again, the United Kingdom, Professor Nuria Alonso from Spain, Professor S.P. Singh from India, Professor Hamid Farouqi from the UAE, Dr. Safa Naqvi from the UAE, Dr. Swera Nadeem from Pakistan, Dr. Manisha Sahe from India, Dr. Aishwarya Krishnamurthy from India, Dr. A.G. Unikrishnan from India, Dr. Khalid Shaikh from Oman, and Dr. Saneh Akanov from Kazakhstan. So, big thank you for all our speakers joining us today from all around the world. I'm indeed grateful and wish to thank all our patrons, vice presidents, and the regional moderators of these sessions, whom you saw before, Dr. Sarita Bajaj, who has been a tower of strength to all of us, Dr. H. Amir, Dr. Faria Afsana, Dr. Sanjay Kalra, Dr. Ali Latif, Dr. Robin Maske, Dr. Mohammad Wali Naseri, Dr. Murthy Pille, Dr. Abbas Rasa, our past president, and Dr. Rakesh Sahe for their valuable guidance and participation today. A special note of thanks goes to our local chairpersons and speakers who are with us today on site, despite their busy schedules and trying times we are having here in Sri Lanka also. They had no hesitation to play an active part in the today's proceedings, and a very big thank you to all our friends and colleagues in Sri Lanka. I'm very much thankful to our sponsors today, CCL Pharmaceuticals and Mr. Eranga, who has been coordinating a lot of things for us, for staying ahead despite change in schedules and all that, and supporting us to organize and undertake this event at this greatness. I wish to express my sincere gratitude and thanks to our technical support group in Sri Lanka, the Blink Productions, Marlon and his team for a wonderful job in coordinating this meeting, the virtual meeting, and of course to Waqas in Pakistan, who is live streaming the event to the delegates of the Pakistan 18th Annual Endocrine Conference of the Pakistan Endocrine Society today. I take this opportunity to thank the hosts of today, the Hilton Residencies, Ms. Thimali and her team, for the assistance given to at such short notice. Finally, but not least, the tower of strength or the pillar behind all this, despite a very challenging times where the two pandemics, the COVID and diabetes, has met, and we are grappling to come to terms with it. But despite all this, it's our very versatile president, Dr. Noel Somasundaram, who has been coordinating all the speakers and putting this program together with the help of Dr. Dimuthu Muthukuda. So I wish to say a special word of thanks to our president and the president of SAFES, Dr. Noel Somasundaram, and Dr. Dimuthu Muthukuda for a wonderful job done. And you will see the quality of the program as the day progresses. And of course, without two people, one person who has really been coordinating all our instructions and keeping the communications channels with all the countries live, Ms. Thivera Chandrapala. I would wish to thank her very much, the SAFES coordinator in Sri Lanka, for all the organization done, and for Sanatani for helping her in this event. So, ladies and gentlemen, I really hope that all the delegates all around the world will enjoy and have an academic feast today. Thank you very much and enjoy the day.